Good morning, everyone. I would first like to thank Gihan and his committee for inviting me to give this lecture. And I also want to thank them for awarding me the fellowship yesterday. I feel quite honored. When we were first talking about what the topic should be for this talk, um, Gihan said it might be a good idea to talk about eating disorders because it is not something that is talked about very much in Sri Lanka. I would like to tell you that it wasn't talked about much even here for quite a long time. It's only recently that people have started talking about eating disorders. So, I will tell you my first encounter with eating disorders. It happened when I was a second year medical student. I had just finished my second MB, and um, I had finished my second MB and started my clinical work. The first appointment I had was a medical appointment. And when I went to the medical ward on the first day, I was given 5 patients, and one of them was a girl called Jayanti. When I went to see Jayanti, she was seated on her bed. She was propped up on her bed. She was very, very thin, and there was a drip running, and there was a plastic bucket by the side of her bed, and she kept spitting into it and also dry retching from time to time. She looked exhausted. I tried to talk to her, but she could hardly speak. So after a few minutes, I gave up and tried to reach the bedhead ticket. And in that, there were a whole lot of investigations that were recorded. And, and also, there were a number of differential diagnoses. There were 15 to be exact. And at the bottom of that, they said question mark anorexia nervosa, right? So I then, that day I went home. The next day I returned. And when I returned, Janti was not there. Her, on her bed, the mattress was folded up. And when I asked the nursing staff what had happened to her, they said, oh, she died last night. She died of a cardiac arrest. So that was my introduction to eating disorders. And Jayanti has stayed with me all these years. It was almost like a baptism from fire for me. So let me take you, before I start about eating disorders, let me take you through the myths that are prevalent, right? People believe that eating disorders are not serious, that they choose to not eat, and that it is about vanity. They do not believe that they are life-threatening illnesses. And they also believe that they are a normal part of life, right? Usually, if with the diets are moderate and the exercise is moderate, has been shown to be safe, but unhealthy dieting practices have a lot of physical and mental health consequences. So, eating disorders are also thought to be a cry for attention. Believe me, they are not. In fact, the people who have eating disorders do not want to be seen. They'd rather not be seen. Families are also blamed for eating disorders. People believe that it is because of certain parenting styles that people become eating disordered. No, it has not been proven that people with eating disorders develop them because of bad parenting. And the last one, which is that the myth about it only white middle class females who have eating disorders, that was dispelled a long time ago, right? It can affect anyone of any age. They can be adolescents, young adults, adults, or even older adults. And it affects both males and females, right? Were you aware that the majority of the jockeys who go for horse racing are eating disordered? They are expected to be strong, but they are expected to maintain their weight below 54 kilograms. So they are either anorexic or bulimic. And they are very strong, but they are eating disordered. So my task today, going back to my first slide, is to show you now, this is, as clinicians, what we see is only the tip of the iceberg. What my aim today is to try and show you the submerged part and see whether we can do anything about it. So let's look at what normally...
Madam, would you please excuse us? There's a little problem of projecting your slides. Okay, now they are coming. Yeah.
Okay.
Please start. Sorry about it.
So let's look at what normal eating is. So normal eating is when you consume food in a mindful way, you eat regularly, and you have variety in your diet. You try to include all types of food groups, and when you're full, you stop it, right? You're able to do that. What is disordered eating? Disordered eating is, it can be restrictive eating, it can be compulsive eating, it can be irregular eating, or inflexible eating. And dieting is one of the most common forms of disordered eating. And I'm sure most of you in the audience would have tried some diet or the other at some stage in your life. There are all sorts of diets now. There are paleo diets, there's intermittent fasting. There are lots of diets available. So people do try for a variety of reasons. So let's look at what eating disorders are. Eating disorders are serious mental health problems. They're characterized by disturbances of thoughts, behaviors, and attitudes to food and eating. And for some people, this extends to a preoccupation with excessive exercise or preoccupation with about body weight and shape. So this is a classification of eating disorders in DSM-5 and ICD-11. As you can see, the ICD-11 has 2 items less than DSM-5, right? But what you're focusing on today is mostly anorexia, bulimia, and binge eating disorder, because they are the most common. So in a nutshell, this is what anorexia is. Anorexia is restricting, checking your weight repeatedly, sometimes several times a day, to see whether you have gained weight, because they're preoccupied about gaining weight. They're very preoccupied with calories, and they're calorie counting all the time. Some of them are preoccupied with body image. So even at very low weights, they see themselves as large when they look in the mirror, right? And some of the anorexics purge, and some of them binge. This is bulimia. And interestingly, bulimics are not easily noticed because they are either normal weight or slightly overweight or slightly underweight. But they too check their weight religiously. They also may have body image distortion, and they binge and purge. But some of them, instead of purging, some of them exercise excessively. And this is binge eating disorder. Binge eating disorder is characterized by eating large quantities of food over a short period of time, even when you're not hungry. You feel really full, but you continue to eat. And the difference between bulimia and binge eating disorder is that in binge eating disorder, you do not purge. There are no compensatory behaviors in binge eating disorder. So why are we talking about eating disorder? One is the extent of the problem. The second is the cost. And the third is the high mortality and the morbidity. In Australia, in 2012, a report was done by the Butterfly Foundation, which works with eating disordered patients. And they said that 69.7 billion was the cost of eating disorders. In USA in 2019, they said the economic cost was 64.7 billion. And in UK in 2020, they said it was up to 11.2 billion pounds. But remember, this is all an underestimate because there's a lot of patients who are hidden and who are not known. So the mortality due to eating disorders is quite significant. Individuals with eating disorder have significantly elevated mortality rates, and the highest is, of course, due to anorexia nervosa. And one of the important things is that the age at assessment is a significant predictor. If you diagnose it early in young people, that means the prognosis is poorer. Right? And 1 in 5 individuals who die of anorexia nervosa commit suicide. When you look at standard mortality rates, you find that anorexia has the highest rate. Then comes bulimia, and then comes eating disorders not otherwise specified. So some of the important things I would like you to take away is that if somebody has been treated as an inpatient for anorexia nervosa, when you compare them to age and gender matched people in the general population, you find that their mortality risk is about 5 times higher. In people who have been followed up for bulimia or anorexia as outpatients, again, when you compare with the general population, you find that the mortality risk is about twice. And all of the disorders, anorexia, bulimia, and binge eating disorder, have a huge impact on the quality of life. Right? The cost of treating these patients is double that of normal patients. Yeah. And eating disorders also carry risks for fertility and health risks during pregnancy and risks to the newborn. Now, let's look at the global burden of disease. That is the number of years lived with a disability and the number of years lost because of premature death. In 2013, anorexia nervosa and bulimia nervosa was added to the global burden of disease. But interestingly, in 2019, binge eating disorders were also added together with OSFED, which is other specified feeding and eating disorders. Right? In 2012, Australia said that the burden of disease for eating disorders was 52.5 billion compared to the burden of disease for depression and anxiety, which was 41.2 billion. So that gives you some idea about the extent of the problem. It's silent, but it kills. So this is the a diagram which shows you the etiology of eating disorders. It's multifactorial. There are genetic factors, there are social factors, cultural factors, and also personality factors. Right? And what you have to understand is that people move between the disorders. The restricting anorexic can become the binging anorexic or the binge purging anorexic. And or sometimes later on, they can become bulimic. So they can move on the scale. Before I come to that, I will ask you, if can anyone in the audience tell me which disorder is the most common, of whether it's anorexia, bulimia, or binge eating disorder? Many of us think it is anorexia. Unfortunately, it's not anorexia, right? It is the least common, but it is the most evident because they lose weight, right? The commonest is, strangely enough, binge eating disorder. But they are an invisible entity because they don't come to us. They don't come to psychiatrists. They go with other secondary problems to physicians. They develop diabetes, they develop hyperlipidemia, they develop hypertension. So they're seen by physicians, not by us, right? So anorexics are evident because of their loss of weight, and they come to us, but not the others. So as I told you, so binge eating disorder is the commonest of the problems, right? So this slide shows you the physical consequences of eating disorders, anorexia, bulimia, and binge eating disorder. And you can see that it affects all the cells, tissues, and organs in the body. Right? The next slide will show you the psychiatric comorbidities that you see in related to eating disorders, right? So all the disorders that we see, mood disorders, anxiety, substance use, OCD, PTSD, schizophrenia, everything, right? But the only thing is, we treat all these disorders, but do we ever think that these people also might be having an eating disorder, right? Because many of our patients on antipsychotics gain weight, right? Do we ever ask them whether they are concerned about gaining weight? Not really, right? We are concerned about it, but we don't really ask them. Right? So you can see that 94% of eating disorder patients have mood disorders, right? So there should be a fair number of mood disorder patients who are having comorbid eating disorders. So these are the attitude of clinicians. One is lack of knowledge and experience, and because of that, we lack confidence and competence to treat them. Then there are the negative impressions that people are responsible for their illnesses, right? And constantly I hear nurses saying, look, they don't want to eat, so why should we bother, right? So then countertransference. Treating eating disorder patients can sometimes be extremely frustrating because it's not easy, and you sometimes feel angry with them. You feel very helpless sometimes because we can't treat them with a pill or a depot injection. You have to develop rapport and start working with them in order to change their attitudes and their thoughts and behaviors. And that is a long process. And that's why you feel frustrated and angry and helpless, right? So many people, many doctors prefer not to treat them, right? They would rather treat other psychiatric disorders. When I treat eating disorder patients as inpatients and try to discharge them, many consultants who are in the private sector, as well as GPs, flatly refuse to accept them. They say we don't treat them, right? It's too hard, right? But fortunately, there are few people who actually try to treat them. So this is the current thinking about eating disorders, right? This is from the quote from the paper by Professor Janet Trescher, who is a authority on eating disorders. She said that over the past 50 years, eating disorders have been increasing, and she attributes it to several factors, but one of them is that the abundance of food that we have and the availability of food. So therefore, she says that healthcare providers should routinely inquire about eating habits as a component of the overall health assessment. So let's look at detection and prevention. One is to try and educate in order to change attitudes. And you know how hard that is, train changing attitudes. And the other thing is to ask the right questions. So how can we change attitude towards eating disorders? One is we try to educate healthcare professionals, doctors, dentists, nurses, psychologists, anyone, right? We should try to educate them all because they would benefit from learning the facts about eating disorders in order to detect them. Because, for instance, it's very commonly dentists who will discover the people who are purging because of eroded teeth. So if they know what it's due to, then they are likely to refer them to someone who can treat them, right? And what has been also shown is that the first few years of training is critical because it allows people to see and assess as they go on. And also emphasize the fact that these are mental illnesses, serious mental illnesses with physical health consequences. So how do we go about changing attitudes, right? We need to educate students and clinicians. We have to educate them about the etiology as much as we know of it. We have to tell them about treatments that are available and how well they can work, and why patients may behave the way they do in order to take away bias, right? And how to interact with patients in a way that validates them without negating them, right? If you are very confrontational, patients do not form rapport with you, and you find it very difficult to treat them. So what can be done within a service? One is education and training. So you have to try. I think we should start with medical students, because by the time they become psychiatric registrars, it's good that we train them, but I think we should start with medical students. Then we also need to support people who treat patients with eating disorders, because as I told you earlier, it is a very frustrating experience. It's long, prolonged exercise, and you get very frustrated during the process. And so you need a lot of support. You need people to discuss it with. Discuss, okay, what options do I have? What should I do next? So prevention. So about prevention, I think we should, again, train all clinicians to ask the relevant questions, explore eating habits, concerns about weight and levels of exercise, right? And then give information about the medical and psychiatric consequences. So do we have a role in the schools? Yes, we do, I think, because children should be made aware of the importance of having a balanced diet. I think they already do, because we talk about Samabara Ahara Velaval in schools. And I think that should be expanded. And we also should make them aware of the dangers of disordered eating. They should be made aware of the influence of media and how it affects their body image. And most importantly, build self-esteem in children. Build confidence and improve their self-esteem. Because one of the crucial factors in eating disorders is their poor self-confidence and poor self-esteem. So we need a different approach at all levels across the specialties. And that is why I think we should target medical students, right? So let's look at what we tell medical students to do when they take histories. We tell them to ask about sleep. We tell them to ask about appetite. We tell them to ask about bowel habits and libido, right? So medical students do ask about sleep. And when you start doing psychiatry, you ask a few more additional questions. You ask, okay, do you have difficulty in falling asleep? Do you have difficulty in staying asleep? Or do you have difficulty because you wake up early in the morning and cannot get back to sleep, right? The same with libido. People ask, okay, how's your libido? You ask the patient says, okay, my libido is okay or not okay. But remember, if you don't ask the patient, would you know, just because the patient's libido is okay, it doesn't mean that the patient doesn't have erectile impotence or vaginismus or premature ejaculation. To find that out, you have to ask a few more questions. So the same thing with appetite. You ask the patient whether how is your appetite? The patient says, my appetite is fine. Patients of mine who have anorexia have said, my appetite is good, when they were eating 1 cucumber a day, right? Because she did not want to gain weight. So unless you ask about eating per se, you do not find out what it is all about, right? So it's good to ask about appetite, but then explore a little bit more, right? Ask them about, okay, do you eat regularly? And if so, what do you eat? Are there times when you skip meals? Are there food groups you try to avoid? Are there times when you feel too full? And are there times you throw up? It doesn't take such a long time to ask a few extra questions. And I think that is what we need to do. Right? Then you ask about weight and see whether there has been change in weight. Find out over what period they have lost or gained weight. And also explore levels of exercise. We routinely ask whether they are physically active, but we don't ask the extent to which they are physically active. They may be spending 3 hours in the gym or running 20 kilometers, as some of our patients have. They run 20 kilometers a day in order to maintain their weight. Some of them want to do that from the ward. So when patients present with anemia or electrolyte imbalance to the emergency department, tell them to explore a bit more and ask a few more questions about their eating habits. And when patients present with diabetes, hypertension, or hypolipidemia, ask them about their eating. I think the crucial thing is to not stop at asking about appetite, but to explore what their eating habits are. Okay, so I leave you with this quote from Sir William Osler, who thought to be the father of medicine. He was a Canadian psychiatrist who introduced the modern training for doctors. And he said that the good physician knows the disease the patient has, but that the great physician knows the patient who has the disease. Thank you.